Hey.
I have two kids at home waiting for dinner when I get home. But I
One.
appreciate the offer.
You're very welcome. I'm very thankful that you accepted. We have been promoting like crazy, but it has been a struggle. For
I got a piece of information. So those microphones are very directional, meaning any slight variation in angle is going to severely affect how well they pick up the signal. So
Do we need them in here? 'Cause
yeah, but
it's a small
it's
room.
being streamed to Zoom.
Oh, got it.
So
you're gonna be nationally online.
Okay.
yeah, so
Great.
if you're not like on top of it, it's going to be very hard to hear. Don't worry, I can bring down the level so it's not too loud in the room, but keep that in mind for the stream.
And it's already on, or?
Yeah, it's on.
Okay, so we just have to, we don't have to do anything.
When, for the questions, I just take mine, because I'm gonna sit there and
Yeah,
ask the question.
correct.
I'm gonna just give an introduction with the podium.
Correct, yes.
And, okay.
You bring, yeah, exactly.
We just take it. So, si fuéramos joven, I would have had it. I was 41, so yeah. Besides, two parents, two kids, two hands, two kids, ya no, no sé how we would have juggled three. Tú con cinco ni lo imagino. Y they're close in age.
Is in Trinidad?
No sé si tú conoces a, I think his niece
He's
acá.
in Trinidad. He's definitely not coming.
Javier es bien retirada. She was very, everybody had their mammogram with her, en práctica privada. Yo no sé cómo era. Janinha, how did you meet Nelsa? Because I was telling her that I met you through Nelsa.
She's Brazilian, so, and, but the first time, I don't remember. We met, I remember we had a Thai lunch where she lives close by, and we spoke a lot about my work. I was, I had a support group. I started out as a breast cancer support group at the library, and then she came to give a lecture. I don't know how I found that. I found many people.
Oh, so it was by chance.
I don't remember because she's well known in the Brazilian community. And then we help a few women that they didn't have, they were insured. So, actually, I spoke to her this week, and she said, "Thank God you are okay. You don't need me," because she's so busy as well, attending events. So,
But she's retired now, right?
no, next year.
No? She's not retired?
No, she sold her business and she works for UN at the
Right,
Leonard
but
Center.
I haven't seen her reports in ages.
No, she told me last week that
She's
she's
still working?
yeah, she's also travels a lot.
Yeah.
She tried to spend a lot of time in Colorado with her daughters and grandchildren. But she told me next year she's gonna retire, and maybe then we can start to do some work together. You know. Do you know Nilza Carlos?
No, but I have been living in Miami for 5 years. 5 years.
Janinha, this is Michelle Mabora. Hi, it's very nice to meet you. How are you? Oh, nice meeting you, and thank you for the opportunity. I really do appreciate it.
You did all the heavy
Very
lifting.
busy this month. Thank you very much.
I don't know if it's a heavy lifting.
No, ya pensé que esto era lo último.
Yeah.
Ya me mandaron un email.
You were-
Que si el viernes, yo
eso, porque yo, para mí, cuando ella me la ella me dijo, yo, ¿será que van a ir? Porque nací en
Thank
México,
you.
y ella te pone,
Yeah, because that's where I was born, pero yo no me considero puertorriqueña. A mí yo no, he regresado creo que un par de veces después porque no tengo familia ahí, you know, for conferences and stuff like that, pero no me considero puertorriqueña.
eso ella me dijo,
¿Y tú dónde naciste? Ah, sí, tú eres puertorriqueña.
de Mayagüez,
Okay.
que ese es el área oeste.
Yo nací en Santurce.
Yeah, yeah, yeah. Am I okay? Sorry.
De donde yo soy, todo lo que hay por ahí es San Juan, Santurce, San Juan, Caguas, toda esa área, le decimos San Juan.
Sí, yo tengo una amiga that went to college with me, que ella vive en Caguas. Sí, porque toda mi familia es cubana, todas las tradiciones son cubanas.
Tú eres de donde familia,
Right. Por eso yo cuando me preguntan, yo digo, bueno, yo nací en Puerto Rico, pero toda mi familia es cubana.
Work. Did you? Good for you. For how long? Are you still on leave or are you back on leave? Okay. So you're really on leave. That's awesome.
¿Y tú vives aquí en la playa, no? Tampoco. So we have a drive. Yo pensé que iba a ser más, que iba a demorar más tiempo llegar.
el tráfico no está, el tráfico no está.
Oh, so you're just gonna be there for a little over a week.
Media hora. Yo pensé que iba a ser más. ¿Y cómo, de dónde tú viniste de Puerto Rico? ¿O estabas en otro lugar?
No, yo vine de, bueno, yo estaba en,
Like, get away.
yo me estudié en México, después fui a Puerto Rico, hice medicina,
Something like that in person.
A La Habana.
Alabama.
Keep us posted.
Oh, Alabama. I was in Havana. I go, wow, I've never heard that.
No, I remember Synergy. I never.
Uh-huh.
Are we starting on time or we are waiting for? Can you hear me well?
Let's wait for Dave.
Yeah, okay. Actually,
¿Estás contenta aquí?
no, you guys gonna start. I forgot.
No, I know. So do you want me to explain what your shirt is? Or do you just, or just
No,
sort of?
you do your part, so I don't have to. I'm gonna just thank you. So
Yeah.
because you, both of you are going to start and then you'll see this also.
Right.
And I have like.
Introduce you.
Porque there's a subspecialized genetics.
Yo me especialicé, pero esta vez especializando así como
But I didn't, but
si la añaden yo sería grandfather, ¿no? Pero yo hice dos extraños que no necesitaba para especializarme en
Should
cáncer
they
de
sit at on
Cancer
stage or
genetics.
should they wait? The two doctors.
And is
Hi.
that a,
Excuse me. This is Deborah from
Deborah
Chairperson.
Sharon, how are
hi, how are you?
Nice to see you.
Nice
Tell me
to
your
see
name.
you.
I'm Dr. Arelis Martin.
Yes. Right.
And Cristina Lopez-Peñalver.
Nice. Okay. So I know one is geneticist. Okay. Got it.
And she's a surgical oncologist.
Ah, okay. And you're both with Miami Cancer.
Yes.
Wonderful. We work with Miami Cancer on a number of things, and they provide doctors for us from time to time. So it's always good to know who's here. Michelle Mavora is Charcher's
Hi, how are
regional
you? Nice to
director.
meet you.
Well, I have been in events. Yeah, but with is that the oh my God, the Victor Center.
Oh, yeah, sure.
Yeah, so I did some events with the Victor
Yeah,
Center.
very nice.
But it was when
It's
I
been a
was
while
in
ago.
Nicola Children's Hospital.
Yeah. Good.
Marcella,
Victor
how are you? Thank you.
No anymore. Because it was when I was
That's an H3 follower. A lot of people are online, Zoom, but he came, so I'm so proud. Oh. community.
Nice to
These are the doctors. These are some of the age group.
Nice to meet you.
Is it anywhere? Anywhere.
Puerto Rico.
Puerto Rico. Yeah. So we have a few from the community, but it's like I said, tonight.
This is actually not a bad thing.
No, it's the political
I-
early
Yeah,
voting
but it's,
time.
it's also just, I think people are not quite
Oh, I have
back
been
in action, you know?
I have been in very many events
Yeah.
this month and not many people.
Well, especially when it's a hybrid event.
Well,
If it's
that's,
a
Yeah.
hybrid
that's what I'm
event,
finding.
people, I think that's one of the things, well, one of the good things and one of the bad things of
Correct.
COVID is that, people get used to doing everything from home. So for meetings, for me, it's great because you
great.
don't have to
It's
leave
great.
the house.
Correct.
But then there's some things that you wanna integrate everybody back in and
But-
get that.
I know,
But
and
also-
Face to
once
face.
there's the option to stay
Yes.
home in my PJs,
Yeah.
Exactly.
But it gets recorded, so I imagine
Alex.
more people will see it.
right.
We have Commissioner Alex Fernandez tonight supporting us.
Good to see you, my friend.
It's good to see you.
I'm
These are
always
the
happy to support
doctors.
you.
Hi, how are you? Cristina
Lopez-Peñalver.
Good to meet you.
Martin Negron,
Awesome. Thank you for doing that.
Charcharet.
Michelle Lavora and Deborah Lupa.
Nice to see you, hi.
Good to meet you.
Thanks for
Now, this is a man that got interested in genetics, and it's like, it's amazing.
Yes.
Also, we have Amani, she's one of the board of directors.
How are you? Good to see you.
Kevin,
Hey, Kevin. Hey.
you know each other, right?
Kevin, I remember Kevin.
Lisa, she's one of the panelists, the chairperson of H3.
Cool.
Caroline, also the new board of director. And you might know Marcelo, right?
Of course, she's famous. Happy to be here.
Did you do a Instagram live? Y después encuentras, tienes a alguien que está en el live que no hay time. Una persona que hace cualquier cosa, me siento desde persona y tú estás hablando algo importante.
We're gonna let them go around 5 to 7 minutes. I know. And, but then
I felt so bad about this conference because esa fue mi culpa.
And so people you
And I was like, yo pensé que era así, que era como, porque siempre te dicen que vaya y son bien complicados. Por eso yo no puedo like this law firm has a couple of branches.
We ready?
Ready?
Danny, should they sit at the couch already, or
What would you like to do? Would you like to introduce them? What would, you want to be on
maybe in the introduction? When I call
I
you,
think we
you
can
can sit down.
I think we can sit.
Okay.
Lisa?
We'll sit on the couch. Okay, perfect.
If not, I feel like we're like on a, getting an award or something.
Caroline?
No, que me caigo, me siento.
Yes. Do you want us in any specific order? Any specific
Whatever.
Déjame tomar una botella de agua.
Sí. Okay.
Good?
That's good.
Good?
All
Okay.
right.
All right.
It's gonna be magenta and black.
Oh, there you go.
I didn't get the notice on the
You didn't have to color coordinate.
Somebody told
There's a little pink, you know.
It's okay.
We're
We're
good.
the same color family.
We're good. If you want to
We're
start,
in the
press
same color
record.
family.
Danny, will you give me a minute? I wanna take a picture with this beautiful panel. Hi.
Hi.
Okay, perfect. Well,
Did
good
you get
evening,
one?
everybody. Welcome. Welcome to Miami Beach JCC. Welcome to our Pink Day and the last week of Breast Cancer Awareness Month. As someone, my wife is a 10-year survivor of breast cancer, and my father-in-law, believe it or not, is about a 15-year survivor of breast cancer. So this is always a very special event. Events like these are always very special to me, to just for all of us to gather and learn and to hear and to listen. And I think I'm hoping for the day, like Star Trek, when they just give you a pill and wave a magic wand and that's it. But that day has not this is something that we are dedicated to doing, is to bringing the community together to learn. Not only, as you passed, you saw the art gallery, you passed our exercise room, which, we are here for the health and wellness and fitness of our community, but also to gather together and learn from each other and learn about things that are important to us, such as breast cancer, and how they affect the community. So I want to thank you all for coming. There's a lot I can tell you about other things that we do. My name is Danny Reed. I am the Director of Arts and Culture here at the Miami Beach JCC in adult programming. So this is, as I said, this is part of what we do, as well as book events, films, special speakers, music. So if you have not come here before, I encourage you to do so and check us out, because we are here to serve the community. So before we continue with the program, I do want to introduce Deborah Lipwak from Chairperson, one of the co-sponsors of this event and this evening. And so I do want to thank Chairperson and of course H3. And I know I always pronounce your name wrong, but Janinha. Thank you so much for being the catalyst for this event as well. So please, ladies and gentlemen, thank you so much.
Thank you.
Deborah.
Thank you. Thank you, Danny. Thank you, Janinha, for really partnering with Chairperson on this event. Janinha was she has the program, and Danny has the space, and it was like, if you know the term shidduch, it's a match made. So we're excited for tonight's program. I am Deborah Litwack, Florida Program Coordinator for Chairperson. October's Breast Cancer Awareness Month, it is here, and you see pink everywhere. You know, bright pink reminders of breast cancer's prevalence in our community. 1 in 8 women in their lifetime will be diagnosed. Chairperson is the Jewish breast and ovarian cancer community, and you wonder, why do we need a Jewish breast and ovarian cancer community? There are so many great organizations, nationally, locally, focused on breast cancer. The reason is twofold. One, Ashkenazi Jews, those Jews from Eastern Europe, have a higher risk for hereditary cancers at younger ages. So in the whole state of Florida, take 1 in 400 to 500 people in the whole state might carry something called a BRCA gene mutation. In the Ashkenazi Jewish community, it's 1 in 40. So Jews in this piece are at 10% more likely to have hereditary breast or ovarian cancer at a younger age. Other related genes like BRCA include ATM and CHEK2, but I'm sure we'll hear about different genes tonight. So we educate about these risks at Chairperson, but we also do culturally competent cancer care for those who face these either breast cancer, ovarian cancer, or even advanced cancers, and those at increased genetic risk. So we are a support services organization. We are a national organization for more than 20 years, and we are thrilled to partner tonight. But it would be remiss of me to not tell you, to remind you that as the month ends and as the months continue, don't delay, pick up the phone, schedule your screenings, don't ignore your annual appointments. Know your family history, whether it's cancer history or medical history. Is genetic testing right for you? That's our question tonight. Chairperson has a genetic counselor. We're going to hear from a geneticist this evening. Miami Cancer Institute has genetic counselors. So lots of opportunities to talk through whether genetic testing is right for you. But most importantly, pay attention to your body. Know yourself. If it doesn't look good, if it doesn't feel right, don't ignore it. So make it Breast Cancer Action Month, not just Awareness Month. So thank you, Janinha.
Thank you, Deborah. I want to thank Danny and Deborah. You have been amazing. Thank you so much for this opportunity. So I have to say good evening, dear audience. My name is Janinha Piazzetta. I am the founder and director of H3 Health Hope Healing. We are a breast cancer nonprofit 501c3, and mainly we work here in Miami Beach and in the areas surrounding us. I really want to take the time to thank the Miami Beach JCC for hosting this event, and Chairperson as well. It's very, very important to say that. It's an honor for us because your support is essential for the continuation of H3's work in our South Florida community, and we have so much more to do. I also want to special thanks to Baptist Hospital and the Miami Beach Chamber of Commerce for their partnership and support. But at this moment, I would like to take a moment to honor those who departed from the world due to cancer. In particular, our local amazing community leader and friend, Deanne Connolly Graham. It's very emotional for all of us, her departure. And on Friday, we're gonna be at the Botanical Garden with a special event. Deanne, thank you. So what is H3? Our primary mission is to educate the public with cancer prevention awareness. We also provide support with cancer patients during the treatment, during and after. We are always following up with them. And we are expanding our services. It's very exciting. We are launching our virtual Pink Ribbon Support Program together with the Pink Ribbon Podcast. So it's very exciting, so stay tuned because in the next few months we're gonna have a lot of good news. And also I wanna let you know about our work. H3 has been recognized by the City of Miami Beach, Florida International University, and Focus Brazil, which is a Brazilian nonprofit foundation. So I have to say that what a journey. It's very emotional, and I get really emotional when I talk about my work. Thank you. So 6 years ago, I created the annual open panel discussion event because I saw an increase in cancer diagnosis and felt an urge to have a community-wide discussion about how to decrease these high rates of cancer incidence, morbidity, and mortality in our communities. So H3 has produced 5 events, and we do have information about our prior 5 open panel discussion on the table. You can have a handout. And it's very important that you know what we have been doing in the past. So for our 6 open panel discussion, we will focus on genetics. And for breast cancer survivors, we'll discuss BRCA1 and BRCA2, positive and ERPR positive, and their treatment protocols. So I want to just go over a very important details about the event before we started. So each panelist, we address the question from their unique perspective. The audience will have an opportunity to ask questions, in the end of the discussion. So please, if during the discussion you have the urge to ask a question, write it down, and I promise you that in the end you have a chance to ask. And for the people via Zoom, we have a chat, and you can always write the question on chat, and we'll be reading your question. You, as a panelist, you have 5 to 7 minutes, and then after the second question, the final questions, we're gonna have 3 to 5 minutes closing statement. So now, without further ado, I wanna introduce you to our very distinguished panel. So breast cancer survivor and H3 chairperson, Lisa Blumetti, surgical oncologist, Dr. Cristina Lopez-Peñalver, from the Miami Cancer Institute, very important, and medical geneticist Arelis Martir Negron, also from Miami Cancer Institute, Baptist Health South Miami. As you all have so many credentials and skills, why don't you introduce yourself? Let's start with Lisa Blumetti.
It's actually very funny that you start speaking to this, don't I? That you say we have credentials and skills, because they're the two with credentials and skills. I'm actually here as the survivor on the panel. Like Janinha said, I am, I don't know if she mentioned it, I'm part of H3. I've been with the group since their inception. I am currently, and since the beginning, the volunteer chairperson on the board of directors. And as I mentioned, I am the survivor on the panel here. I was first diagnosed in September of 2006 and started my surgery and my treatments in February of 2007. And I'm still in active treatment. I was actually diagnosed with stage 4 metastatic breast cancer. So it spread through my lymphatic system and pretty much into most of the bones between my hips and my shoulders. So I've been in active treatment for 15 and a half years. So I'm really looking forward to hearing what the medical professionals have to say about the genetics and the latest research and what we can all look forward to finding out about in that field. Thank you.
Hello, thank you for the invitation. My name is Arelis Martir Negron, and I'm a medical geneticist. My background is internal medicine, and I did genetics and cancer genetics at City of Hope. Now in the current work, I'm the medical director of clinical genetics, and we have genetic counselors, and we serve the entire MCI. We see patients with breast cancer, but with other conditions, and they mentioned breast, they mentioned ovarian, but the BRCA1 and 2 mutations are also associated with other cancers. And I usually see the patients to discuss test results, and I'm here available for any questions you may have.
Hi, my name is Cristina Lopez-Peñalver, and thank you for the invitation, Janinha. I think this is my third time with you, and this first time in person. So I am one of the breast surgical oncologists at the Miami Cancer Institute, one of 5. I've trained and did all my training in surgery and medical school, everything at the University of Miami, so I can kind of say I'm homegrown. And I'm excited to be here and share some of our latest developments with you.
Thank you, dear panelists. So for our 6th open panel discussion, we'll focus on the following questions in depth. The first one, which is one question but has 2 questions actually, 2 questions in one question. Do you think genetic testing is a valuable tool for diagnosing, treating, or possibly preventing breast cancer? The second question, are there currently reliable tests for genetic markers indicated in a specific racial or ethnic group? So I believe that I want to start with Dr. Martin Negron, please.
When a patient, an individual, come to have genetic testing, one of the things that we say is genetic testing, even if you have a positive result, cannot tell me if you have cancer at the moment. It will not tell me if you develop, it will develop. What it is telling me is if you are in an increased risk compared to the general population. Is a vehicle, so doing the genetic testing, then you know that you carry a genetic predisposition, and then with that information you can have better screening that at the end hopefully will result in early detection, or in some cases prevention of or risk reduction. Genetic testing it doesn't work for the diagnosis, but it's more to see if you are in an increased risk, what will be the recommendation. It can be also used for treatment purposes.
So I think that genetic testing is a very valuable tool because it can help us to determine if a woman has inherited a genetic mutation that significantly increases her risk of developing breast cancer and other cancers, and that information can then be used to determine what steps the woman can take to prevent or reduce the risk of developing that cancer. And I think I like to divide the way this information is used into 2 subsets. So how this applies to women who don't have a personal history of breast cancer, and how this applies to women who have a personal history of breast cancer. So for the first group, those women who are healthy, who are asymptomatic, don't have a personal history of breast cancer, they can use this information to direct or inform decisions about future health care. So for example, what can the woman do to reduce her risk of developing breast cancer? What can she do to reduce or prevent the development of breast cancer? And I think the most effective means of preventing is with preventive surgery. So for women with a BRCA mutation, we often recommend, again, this is individualized, but we often recommend risk-reducing mastectomies or prophylactic mastectomies, double mastectomies, which offer the greatest risk reduction with over 90% risk reduction for breast cancer. We can also offer risk-reducing salpingo-oophorectomies, which lower the risk of developing ovarian cancer and fallopian tube cancer, which are cancers that are common in these carriers. However, some women may decline the option for a mastectomy, or they may postpone the mastectomy until, for example, they found an intimate partner, or they've completed childbearing and nursing. And for these women, we also have the option of medication, chemoprevention, which can be used to lower their risk of developing breast cancer. And depending on the medication used, that can be anywhere from 50 to 60%, as well as what we call high-risk surveillance. So watching these women more closely with mammograms, annual mammograms, and MRI alternating every 6 months for starting at age 30, which will allow us to detect something early and hopefully detected when the chances for cure are the highest. And then for women who do have a personal history of breast cancer, they can use this information to tailor therapy. So women who have breast cancer can choose to have bilateral mastectomies, one to treat the affected breast with the cancer, and the other one to prevent a second cancer, because we know that in this population, their risk of a second breast cancer is significantly elevated. And that information can also be used to tailor medical therapy. So the BRCA genes are responsible for repairing damaged DNA. And in this population, we like to use specific types of chemotherapy agents that disrupt DNA repair mechanisms, such as cisplatins, and also medications such as PARP inhibitors.
And I want to say something to add to what she said. Is that there are 6 genes that we call high-risk breast cancer genes. And when I said BRCA1 and 2 is the same as BRCA1 and 2, is that BRCA was the analysis, but the gene is called BRCA1 and 2. Besides the BRCA1 and 2, there are genes like TP53, PALB2, PTEN, STK11, and CDH1. And those are the genes that, if you look at the percentage of risk, it seems that the guidelines, we follow the National Comprehensive Cancer Network guidelines, it seems that when a risk is over 50, if it crosses that, then the recommendation is to remove the breast prophylactically, okay? So we have, and it doesn't have to be 50 plus. We have genes that have 30, 20 to 60%. The BRCA1 and BRCA2 are more than 60%. So those are the ones that when there is a pathogenic mutation, we will say this is the recommendation. Prophylactic mastectomy is an option. You can always do mammograms alternated with MRIs as screening. But these are the ones that we recommend the consideration of removing the breast prophylactically. When we talk about somebody, when we see somebody who comes and already have cancer, there are other genes that in the guidelines said that there is insufficient evidence, and even when somebody doesn't carry, is unaffected. there are some genes that says that there is insufficient evidence to recommend prophylactic mastectomy. Let's start talking about the one that are unaffected with cancer. And for those, what we do is there is insufficient evidence. It's a discussion to have with I always say with the breast surgeon. And obviously the breast surgeons have to discuss the medical necessity in order for insurance to cover. But we also look at the family history. So it said insufficient evidence, look at the family history. So if there is a family history with very strong breast cancer in multiple family members, bilateral breast cancer, that has to be taken into consideration. When we have somebody who already has cancer and they come to see us for surgical decisions to determine if a lumpectomy versus bilateral mastectomy is a mastectomy is an option, or a bilateral mastectomy, obviously if there is a mutation, looking for the possibility, what is the risk for a second breast cancer. For BRCA1 and BRCA2, those are the two genes that we have clear numbers, and it took 20 plus years to have those numbers. What is the risk of a second breast cancer? And having that information, knowing that the risk is high, for BRCA1 is 40%, for BRCA2, if we round it off, is 27. I said 30 to make it easier. The risk is enough that there is a point of deciding to have a bilateral mastectomy. But if I see a patient who carries a mutation but is in one of those genes that we don't have the data about what is the risk for a second breast cancer, since the patient is going to have surgery, I have to discuss. So this is what is going to happen. If you have the surgery, because you carry a mutation, if you decide to do the lumpectomy or mastectomy, depending how big is the cancer, they will need to have, as a follow-up, screening with mammograms alternated with MRI forever. And that becomes, I would say that 90% of the patients will not like that. They don't like to, after you have the experience of learning that you have cancer, to think that you have to go every 6 months to be checked. Many decide to have a bilateral mastectomy, even when in the guidelines there is no clear recommendations to remove the other breast. So there is the guidelines, and there is many things that goes with each patient. Each patient is very different, and you have to take that into consideration. And I always send the patients back to the doctor to discuss that. So I don't know what it goes with that discussion,
Well, I think it's an important point that you brought up, because I think it's easier for patients who have a personal history of breast cancer to make the decision about bilateral mastectomies than patients who don't have a history of cancer and have just been tested because a relative was found to be positive. So they're young, they're healthy, they feel well, they don't really understand what all of this means, and it's a little harder for those patients to choose preventive surgery than for someone who has a known genetic mutation, be it a BRCA1, a high-risk mutation, or a moderate-risk mutation, because of the reasons that Arelis just mentioned, that they've already gone through treatment, they don't want to go through treatment again, they don't want to go every 6 months to get imaging, they don't want, and have to worry, the anxiety about worrying if something new is going to pop up. So those women generally tend to choose bilateral surgery.
Lisa, do you want to say anything about it, please?
Sitting up here with two doctors, I feel woefully unqualified to rig this question. So as the survivor, I will just share with you my personal experience with BRCA1 and BRCA2 because, like I mentioned, I was diagnosed about 16 years ago. And at the time, the genetic testing was still kind of on the newer side. I believe at that time there was one lab in the whole country, and they were in Utah, I think, and they were the only ones.
Yeah.
Yes.
There's probably more doing it now.
Yes.
Lots
Yeah,
more.
a lot more. So back when I had the testing done, there was one. And I'm not sure exactly why I was counseled to have the genetic test, because in my mind, I figured, well, I already have cancer. What do I need the test for? Like, if I already know I have it. I don't have any sisters. I wasn't planning to have any children. My brothers only have sons, so I couldn't really justify, having this test, but they said just do it anyway. So, and I'm also of Ashkenazi Jewish descent, so I had the BRCA1, the BRCA2, and the Ashkenazi panel, and I was negative for all three. And I find it interesting that there's got to be a difference between hereditary breast cancer and genetic mutations for breast cancer, because my mother died from breast cancer that spread to her liver. I have breast cancer. We're both negative. Most of the women who I know who have cancer are also negative for the genetic mutations. So I'm just curious, and I don't even know if there's any sort of definitive answers with this, if you have the difference between hereditary breast cancer and a genetic mutation for the cancer, and how, is there a chance that I've inherited the breast cancer because my mother had it, but I can still be negative on the genetic panel?
There are many things that,
Too much of a question.
First, let me tell you, I don't know, I don't know about Cristina, but I have all the theory, but I have not gone through what you have gone through. So you are is very important. The experience that you have is not my experience, and I don't know Cristina, but that's first. So then second, when it's true that there was only one lab doing the genetic testing back then, and it was because there was a patent for the BRCA1 and BRCA2 genes of everybody in the United States. And even if you say, well, I'm gonna go to Europe to have the genetic testing, that you still have to pay the same amount of money because that patent. And yes, at that time, this only lab, the test was very expensive. It wasn't anything different than any other genetic testing done for other conditions. It's just that there was a patent, and they have this monopoly. When somebody is, I think that there were two reasons. It was in 2007. I think that I don't know your age, but I imagine you were. In my 30s still. Yeah, so because you look young, and you were younger than 45. Now is younger than 50. There have been many changes. The latest is a 50. But let me tell you, the American Society of Breast Surgeons is recommending that everybody who has breast cancer should have genetic testing. Also, their labs, even if they're, because it's not in guidelines, it's a recommendation from a big organization, there are labs that are offering that service to no cost to the patient. So this is now. Now, back then, the insurance will cover, in your case, they could have covered the entire BRCA1 and BRCA2, okay? Because the three Ashkenazi Jewish mutations are 2 mutations in BRCA1 and 1 mutation in BRCA2. And their founder mutations, you see founder mutations, and that is one of the questions. You see founder mutations in populations that for some reason they were close, or they were marriages amongst the same population. So you will see it for religious purposes. So for many years, it's a religious cause. They were marrying amongst the same population. You can see that in islands. For example, there is in the Bahamas, there are some, there are founder mutations. You will see it in people that live in places, in mountains, or in small communities. You will see founder mutations. So it's not only the founder mutations or seeing a mutation that is common in the population. It's not only for the cancer genes. I'm from an island, and there are many founder mutations, not necessarily about cancer, but other founder mutations. So that is what you see common in the population. For the Ashkenazi Jewish population, there are those 3 mutations that the chart shared was saying, the person for Charlotte was saying 1 in 40, and that is correct. But those are not the only genes associated with breast cancer. And also it's recommended to check the entire mutation. Yes, 95% of the mutations in the BRC in the Ashkenazi Jewish population are those three in the 95%, but there still could be other mutations in the gene that are not one of the founder mutations. Also, you could be of Ashkenazi Jewish descent, but then also have some Sephardic. And for the Sephardic, there is not the 3 Ashkenazi Jewish mutations. You can find other mutations. Something very important, the second most common mutation in the Mexican population is an Ashkenazi Jewish mutation. And is because the Inquisition. So when happened the Inquisition, many people, there were people, it's Northern European because people moved there, but many of the people from Spain, they were not Sephardic, they came to the Americas, and they have to change and they have to say that they were not Jewish, and many people doesn't know that they have Ashkenazi Jewish in the family. So sometimes I see patients that are, let's say, from Mexican or Latin American, and they come, and I say, well, I have 2 things to tell you. You carry a mutation, and you are of Ashkenazi Jewish descent. So that is something that had happened to me many times. And there are other genes associated with breast cancer. Those are not the only one. So to answer your question, if you haven't had any genetic testing, or only that one from 2007, that is incomplete. You need more testing.
Why would I need more testing? Like, to what end? I mean, I'm still in treatment. I've already had surgery. I'm not having children. I don't have any sisters. My mother's already passed. So I guess I'm just wondering, to what end? What's the point? What would be the reason for me to have genetic testing?
And that is a very good question, because these are syndromes, and they're associated to more than one cancer. So it's possible that, first, that will explain. So you say, there is my mom and I, could it be possible that there is, what could be the explanation? Well, we have the hereditary cancers and we have the familial cancers. The familial, in the past, we used to say 5% of the cancers are associated with a genetic predisposition. Now, it's 10 to 15%. Why? Because from the familial, as we learn about other genes associated with breast cancer, those people in that group have moved to the hereditary because we have learned that there's some genes like ATM. ATM is associated with breast and pancreatic cancer. Then you have CHEK2. It's associated with breast and colon cancer. Let's take that example. If somebody has a CHEK2 mutation, somebody like you, then it could explain the cancer. But then now you know that you are in an increased risk for colon cancer and you need more frequent colonoscopies. So
you mean I have to go get my first colonoscopy?
But I think it's important what to mention that, because I see a lot of patients that have had genetic testing in the past, and I think it's important to know the year that you had the genetic testing and the type of genetic testing, because there are different options for genetic testing, different genes that are tested, and you want to make sure that you've been tested for all the relevant genes, because like she mentioned, you could be at risk for other types of cancers. And even though you don't have children, you said you had nephews and brothers, and this can also affect men. So it can also increase the risk of breast cancer in men. It can increase the risk of prostate cancer. It can increase the risk of pancreatic cancers. So that's important. And another thing that you brought up that's interesting, and it's kind of hard for people to distinguish, is the difference between hereditary and non-hereditary cancer. So all cancer is genetic. All cancer is genetic because it results in mutations in genes that control abnormal growth of cells. So, and that can happen either because you inherit a faulty gene from your mother or your father, or it can happen because of, lifestyle factors. There's no single cause to what we call sporadic breast cancer, which is not hereditary, but it can be lifestyle factors, it can be aging process, it can be, environmental exposures, and all those things contribute to cause mutations in a cell. And over time, as those mutations accumulate, eventually it knocks out your two normal genes that you were born with, and you develop a cancer. So all cancer is genetic, but not all cancer is hereditary.
So on that note, we have the Afro-American women. There is a disparity of breast cancer.
We cannot hear you. You must be open mic.
Can you hear me now? All right, I'm sorry. So I was saying the Afro-American women are having a disparity of breast cancer diagnosis. What is the main factor that is causing this disparity? What genetic markers are relevant for this group? Are there also socioeconomic or other factors that come into play?
So African American women are less likely to develop breast cancer than white women. So about 4% less likely the incidence is 4% less, but they're more likely to die of this disease, about 40% chance more likely. And it's not, the causes for the disparity, I think, are multifactorial. Some of it could be due to lack of access to good care, lack of screening, lack of access to equivalent treatment options. But in terms of genetics, you want to comment on that, Adelis?
Well, there is also something that the triple negative breast cancer is also more common in the African American population. So I see all of them because everybody who has triple negative breast cancer should have genetic testing. But we established that every woman with breast cancer should have genetic testing. And that tend to be more aggressive, and it has to be treated with chemo. And that is one of the reason we have to take that into consideration. Something else is that I have had cases that I see patients that come to see genetics, and remember, there was many bad things that were done in the African American population in terms of research, and it's very, you can understand why sometimes they don't feel comfortable participating in research and even being tested. And in some cases, the patient, although I would say this was more common 10 years ago, I think that more people are aware about genetic testing, but I had cases in the past like that. So we have to take that into consideration. But also, very important is that many in the population tend to have a cancer that is more aggressive than that white. And I don't know if you agree with that.
Yes, I mean, there is definitely a higher incidence of triple negative breast cancers. And I think a lot of it is due to they don't get screened the same way. They don't have access to screening, whether that's because of a socioeconomic reason or insurance reason, or lack of education, but they don't get screened as often. And when it's detected, they're not usually treated the same as white women, and those are some of the factors that lead to that disparity. So that's why it's so important, with these events that we have, to reach everyone in our community, because this is all about education and awareness, because the sooner that we're able to detect something, the more options that are available for women, and the higher the chances of cure.
And when we talk about diversity, if we talk about diversity, that we need more people, we need more diversity in the genetics data. And that is very important, because when I see a patient and there are 3 possible results in genetic testing: positive or pathogenic means that you were born with a genetic predisposition. Negative means that no mutation was detected, but we give recommendation based on family history because, like I said, family history is very important. And third is an inconclusive. There is a change, but we don't know if that change is suspected to cause problems because we haven't seen it in enough individuals. I call it negative until proven otherwise, because really, in the majority of cases, are benign changes. But what happened? When they're comparing these results, they're comparing to the data that have been the different registry, and the majority are Northern European and Ashkenazi Jewish. what happened? In my clinic, I have a high numbers of variant of uncertain significance because maybe I serve 80% of Latin American population, and this type of testing is not happening in Latin America. So we really need diversity, and the same with any population that is not Northern European and Ashkenazi Jewish, I will have higher numbers of inconclusive. And inconclusive could be a common change in that particular population. But again, if more people doesn't get tested, the diversity, if more people, and is being tested also participating in research. Diversity in participation of research is very important in order to advance science.
Thank you. We have 10 minutes left, so we have a second question, and then we will have like 5 to 8 minutes for questions. So let's go to the second question, which is for breast cancer survivors who are BRCA1 and BRCA2 positive and ERPR positive, how important is it for their treatment protocols to be modified or updated, especially after the standard 5-year mark? Dr. Lopez-Peñalver, please.
So for ER-positive patients, and these are for BRCA carriers and non-BRCA carriers, we obviously do the standard of care, which is standard of care chemotherapy if it's indicated, hormonal therapy for 5 to 10 years, and I think that somewhere right before the 5-year mark, we have the ability to test tumors to see what the risk of a late recurrence is and what the benefit of extending the hormonal therapy beyond 5 years is, and use that information to decide whether to continue hormonal therapy or not. I think in BRCA carriers specifically, if they have intact breasts, so if they've chosen not to have a mastectomy, that we can consider continuing the hormonal therapy more for that chemopreventive effect of preventing a second breast cancer. And then in addition to that, I also think it's important for these women to continue screening, so for other cancers that they are at risk for. So if they have intact breasts, we continue screening for breast cancer, like Dr. Negron said, for life. So we continue with mammograms alternating with MRIs. We continue to screen for ovarian cancer, which is not very effective, but if they still have their ovaries in place, we continue to screen for ovarian cancer. We screen for, we can talk about screening for pancreatic cancer, screening for melanoma, and men screening for prostate cancer. So it's important to continue screening for life.
Thank you.
Yeah, having an ERPR positive cancer with the development of medications that have helped to treat without the need of chemotherapy is very important. So it's important even if you carry a mutation or if you don't carry a mutation, it's good that we have those tools to help. The standard is the same for patients with BRCA mutations that are ERPR positive. The difference is if somebody has metastatic breast cancer, and this is something new that is available now. If somebody has metastatic breast cancer and they carry a BRCA1 or BRCA2 mutation, there are these medications called PARP inhibitors that take into advantage the defect that having a mutation causes, and it tackles another of the system that the tumor have to survive. So because one is already damaged, then tackling this makes the tumor cells to die. So this is PARP inhibitors have been around maybe 5 years, and it have been very good for the treatment of metastatic breast cancer, and more so for the maintenance of in patients with ovarian cancer. So that is something that is specific for patients with BRCA1 and BRCA2 mutation. Now, the same type of mechanism is shared by other genes, like PALB2, RAD51, RAD51D, RAD51C. But now it's only available for BRCA1 and BRCA2, but there is potential for the use of these medications if it's approved. And it's very important for everybody who was tested in the past or in this population, people that was tested only for the 3 Ashkenazi Jewish mutation, that is a good idea to come back to genetics and have genetic testing again, because there have been very many advances, and you can, it can be important for treatment purposes. Do you want me to talk about? Okay.
Well, we don't have much time,
Okay.
so Danny, should we go over the questions? I just want to remind the audience that, let's stay on the question, because we have tendencies to tell the public our experience, but as we have very little time, so let's just focus on the question only. And is there anybody here who has a question?
It's a question and a comment. As a 2-time cancer survivor, number one, congratulations, and you do have a lot of merit because you've been living through it. So don't ever say that again, seriously. Don't ever say that you don't have merit to be there.
Oh, no.
I'm a 2-time cancer survivor.
I said I'm
Yeah.
woefully unqualified.
Oh,
from
no,
a
you're very
scientific
qualified.
standpoint.
You've been living through it. I sit on panels with doctors all the time. I'm the only non-doctor, and I've learned I'm an immature teratoma, 3 days to live. So I will tell you that. My question and kind of a comment also is about thinking about when you were talking about the different, having more. Most of it is cultural, right? We don't have the culture I'm from Puerto Rico, but then you look at Latin culture, African American, there is a hesitancy to get tested, right? So that's why we don't have that. I think you said social economic as well. But the other part of it is that when you do survive cancer, it's almost like most of the people that I get to talk to, I speak all the time. I was just in Washington, D.C. talking about this. So I'll just tell you that, it's really hard to have to get tested every year. And I think when I go to these medical conferences, it's almost scary to keep listening. We have to figure out, I don't know, again, that's kind of the question it is, how do we figure out how to explain these things in a way that people want to keep living, because it also is a mental barrier. And the second part of it is exercise. I exercise at 128 pounds with an immature teratoma under 14 chemos per round. And I still exercise, and I train people to let them know exercise. Now, doctors are saying it's good to exercise. So those are the 2 things that I wanted to ask. Thank you.
Okay, the first question about genetic testing is not every year. Is when we talk already about the patent. When the patent. Yeah. So when the patent. How about now?
Can you switch? I don't think it's working. Yeah, can we switch? Sorry.
How about now?
There we go.
Okay.
Perfect.
Maybe I pushed
It's the
something
mic.
there.
You're perfect.
It's off. Okay. Okay. So I was saying that when remember the patent, and we knew at that time we were testing only for the BRCA1 and BRCA2 gene, but we knew about other genes associated with breast cancer. But it was economically impossible to be tested for a gene that was 2 genes, $4,000, and in addition to be tested, and the panel was not possible if you cannot have the most common genes associated with breast cancer. That was a big change when we moved from 2 genes to have a panel gene. The panel gene has remained the same, very few changes for the past 5-7 years, and it's not every year. What we do is we test the patient, and usually we do a large panel if the patient allowed, and in that panel we're testing also for genes that we believe are associated with breast cancer, those who we know and those who are believed. So those are the ones that will make it to the guidelines. It's not every year, but for people that were tested in the 2013, before 2013, it's a good idea to come back and get retested. And you can talk about the lifestyle modifications.
So I just want to reiterate, and I actually saw a patient today who had breast cancer in 2003, had never been tested. She has no evidence of disease. She completed her treatment, her surgery, her chemotherapy, and just got tested because her gynecologist decided last week that, or a couple weeks ago, that he was going to test her because she developed breast cancer at a young age and she came out with a BRCA1 mutation. So it's important to know that just because you've had breast cancer in the past, it's important to know when you got tested and what type of testing you had, because it's not every year that we recommend genetic testing, but whenever there's a change and there's an update and new genes are discovered and they're added to the panel, those are things that you haven't been tested for. So if you're at risk for those particular genes and those mutations that increase the type of cancer that you have, then you may need to get additional testing. And then the second part, exercise. So other than, medical therapies that lower risks of developing breast cancer, other than surgery, medication, there are certain lifestyle modifications that we encourage, specifically for breast cancer patients, to lower the risk of developing breast cancer or having a breast cancer recurrence. And those are eating healthy, losing weight if you're overweight, and exercise, and limiting your alcohol intake. So all of those things specifically for breast cancer have been shown to reduce the risk of breast cancer. So exercise is very important. It's not only important for your mental health, but it's important to reduce your risk of cancer.
Can I add something to that?
Absolutely.
So I agree with that 100%. It's totally lifestyle. And I honestly think one of the only reasons I'm still alive today is because I only eat organic produce. And I know people think it's ridiculous, and I've had people say to me, well, I can't afford to eat organic. And I say, well, I can't afford not to. You spend your money where it's important to you. And, I have triple positive breast cancer, which in some ways is fortunate because, from my understanding, it makes it easier to treat. I'm ERPR positive, I'm HER2 positive, and I'm still in treatment. I've had no progression of disease in 15 years. At stage 4, and I also haven't changed my treatment protocol at all because it's still working. I've actually taken myself off of 2 drugs, but from my understanding, a lot of plants, fruits, vegetables, produce, the pesticides and the herbicides they use are so full of endocrine disruptors that I think that really contributes to a lot of the breast cancers we're seeing, and possibly other hormone-related cancers, that people don't really take into account how important it is, what you put in your body. And not just that, but your skin is your biggest organ. So what you put on your body is also important. If you're slathering your body up with all sorts of, chemicals and filling your body with chemicals, it's not going to produce good results in the end. That's my opinion.
Wilasu, please, would you describe the test? What is the test? What we expect to go through getting the test, and where would we go to get it?
Yeah, the test is this working?
It is.
Can you hear well?
Okay. Also, these are like
Yeah,
omnidirectional.
better.
Thank
yeah,
you, thank you.
Now, yeah. The test is, it could be saliva, although I prefer blood. The reason I prefer blood is there have been many changes in genetic testing, and I want to say something very important. If somebody has to pay out of pocket for genetic testing, it's $250. Okay, it's not $4,000 anymore. But in the majority of cases, this is covered by insurance. And also, there are programs that the lab offers, and in many cases, the patient doesn't pay. It's a blood test. It's saliva or blood. I prefer blood because we are doing DNA and RNA. So the DNA is what is in the nucleus, and the RNA is really the one working hard. It's the middleman. It goes to the nucleus, remove information, and that information is used to make a protein. The purpose of a gene is to make a protein. So having the RNA can help to reduce, depending on the mutation, the numbers of variant of uncertain significance, and we don't want that, right? The test is, before we do pre-testing counseling, we discuss what to expect and what not to expect from genetic testing. And also we identify if you are the best person to test or there is somebody else that is a better person to test. We see what are the cancers in the family, and we recommend what are the genes that need to be tested, and we talk about cancer panels. Testing happen. it takes approximately, depending, if somebody is making surgical decisions, we can have the high-risk breast cancer and some of the moderately increased risk cancers, we can have it 7 to 10 days. Yes. And I have been telling to patients in the past 3 to 6 months to have genetic testing, so this is very fast. And the remaining of the genes we receive after, but we provide the information to the surgeon, the information of the genes, so they can start the process of surgical planning. When we have the results, we discuss in detail. So that is the process. Pre and post, ideally. You can find places that do the testing without explaining, but I have noticed that would you explain, and it's not just me, it's in every organization, and it's recommended by the NCCN guidelines, is that it can reduce the level of stress. It can help when you go and see the patient in the next visit, is you do a summary and all the information is better taken. And then since when you see the patient in the pre-testing, you explain some of the things that if you carry a mutation, what will be your changes is less scary. And that is the process. You go to, okay, so you go to Miami Cancer Institute, but you don't need to go, because maybe the only good thing about COVID is that we do telehealth, and it's still allowed by insurance. As long as the insurance allowed, we can do telehealth. And I was doing telehealth before telehealth was cool. When I was in California, and we were serving a community that we did the service for free, and this is why we could do telehealth. Cancer genetics is perfect with telehealth. We don't do a lot of clinical examination, and if there is a need, we will follow in the follow-up, we do the the physical examination. But we discuss in telehealth, and we do the test results, and the lab will send people to do the blood draw at home. So there is no excuse.
Great. Do we have time for one more question? Okay, Ora.
I'll come to you.
Thank you, Ora.
I have a question.
Right there.
1, 2, 3, testing. Okay. This is perhaps not related. I'm not 100% sure, but I'm going to try. I already have CLL since 2014. Okay, so that's, I got nervous. That's blood cancer. And so in the last 6 years, I've been on different chemo pills. And the last chemo pill apparently has worried my oncologist that it caused me breast cancer. So I received a mammogram. And after I received the mammogram, I was told that now I have to have a biopsy, which meant that I would have a titanium placed in my breast. I refused the titanium because I just felt that it didn't make sense that if I already have cancer in my blood, that I should put a titanium in my breast. So I stopped. Now, I'm at that point right now, and I was just wondering, will it help me at all to get a DNA test, a genetic testing, because I'm just not going to do it. Also because I was, one more sentence, I was traumatized in the 80s where I was actually laying there on the bed about to get my left breast removed, cut off, boom. And the last moment my friend came in and said, but you didn't have a second opinion, and took me to UCLA, and they did a, what is that called again, the needle, they put the needle.
Biopsy?
Not a biopsy, it's a fine needle, aspiration. And said, oh my goodness, you have so much milk ducts, and I do still, I know. I mean, I breastfed both of my sons for 3 years each, and I know I still have it there. So is there any other way? Thank you.
So,
Thank you, Autumn.
So first of all, genetic testing doesn't substitute screening, mammographies. That's, for the last 50 years, mammography has been the gold standard for screening. Most biopsies do not result in cancer, so most abnormalities are not cancer. However, when we do a biopsy, which is typically a core biopsy with a needle, we do insert a metallic titanium clip. Titanium is inert. It causes no problems. The clip is so small, you can't see it with your eye. But it is visible mammographically, so if it ends up being a benign biopsy, that area can be addressed in future mammograms more carefully because it directs the radiologist's eye to that area since a biopsy has been performed. If it ends up being a cancer and it was a small lesion to begin with, it serves as a marker for the surgeon to be able to know where the cancer was. So there is no other way to diagnose a breast cancer other than a biopsy. So there are imaging modalities that can be suggestive of cancer, but the only definitive way to diagnose it is with a biopsy. And a metal clip, a titanium clip, will not cause any problems. It's MRI compatible, so it doesn't interfere with any future imaging. And you can have a biopsy and not have a clip placed if you choose not to have a clip, but it's not good practice.
And I have to say something very quick. Because it's chronic lymphocytic leukemia, when we do genetic testing, I mentioned blood, I mentioned saliva. I did not mention that we need to do, when there is active leukemia or bone marrow transplant, we need to do a skin biopsy. We cannot do blood, we cannot do saliva, because there's going to be a lot of mutations, and we need to make sure that what we found is really in every cell of the body and not just in the blood.
Wow, thank you, thank you.
Well, wow, and I bet you, I mean, now is not the time, but Lisa, correct? So, I bet you we could have a whole panel of just breast cancer survivors to talk about how they navigate the system. Because I just want to even give you the last word. I don't know if you have a couple minutes or a minute comment. Just, you said you've had cancer actively for the last 15 years. And how have you navigated that? And how have you, I guess I'm trying to ask, you're managing your life, you're managing your health, and you're working with, I'm assuming, over the last 15 years, a whole series of doctors and medical professionals. How, I don't know, and I guess this is a long question. You can have a long answer, but in a minute, can you just talk about how you navigate that? Like,
I can do better. I can do better than a minute. I can do it in a word.
Yeah.
Apathy. That's it. Yeah. I've never really been the type of person who gets terribly emotional about things that affect me. So I had 7 biopsies and MRIs and 7 surgeries in a year, and I've been in active treatment for 15 years. But I never had that why me moment. I didn't. The morning the doctor called to tell me that my biopsies were positive and I had cancer, he woke me up. And I was tired, so I didn't cry, I didn't call my mom, I didn't call my dad, I didn't call my best friend. I went back to sleep because I knew I was still going to have cancer when I woke up and nothing was going to change. So it's just, and I think it's a little bit unusual because most people aren't as apathetic about it as I am, I guess. I just kind of, maybe apathy isn't the right word because it kind of minimizes, I don't know, maybe it minimizes how impactful this really should be in my life, but I didn't want it to define who I was or what I did, and nothing in my life really changed except that, I have to go to the cancer center every 3 weeks and get my peripheral IV hooked up, and I've got to have an injection in my stomach, and, it kind of throws a curveball into my life, but it hasn't really ruined anything, and I kind of feel like every single day I leave my house, I see someone I wouldn't want to trade places with, and as long as that keeps happening, I can keep leaving the house, And it's true. And, you know, it's funny, you know, we're talking about genetics and how things have changed over the years. And, you know, I'm just curious. And you talk about, you know, needing more diversity and having more data. I wish there were more people like me to do studies with. Like, even my doctor doesn't know what to do with me at this point. You know, the doctor, so I've been on Herceptin for 15 years, and my doctor says, you know, he's met the doctor who discovered Herceptin, and he only keeps his patients on it for 3 to 5 years. I've been on it for 15 years. You know, so with no, like I said, no progression of disease, no change in treatment protocol, and I'm curious, maybe even from a genetic standpoint, like, what's going on in my body that's, you know, keeping this machine running with all this, you know, the drugs and the time and everything. So I know it's been longer than a minute, but that's what I have to say.
I have been pushing Lisa to offer her journey with science because it's amazing.
Janinha wants me to devote my body to science.
No. But it's amazing, her journey. And that's why she's on the panel, and she's the chairperson of H3, and she's my good friend. She's my hero, so.
Well, listen, I want to thank you, Gina, for bringing this to the Miami Beach JCC, and thank you to this wonderful panel. Everybody who is in Zoom land, thank you so much for joining us tonight, and for everybody else who came here. This has been an educational evening, I hope, for all of us, and an enlightening evening as well. So I want to thank you all, and wherever you are, if you're healthy, if you're sick, or if you're, you know, an out of shape, schleppy middle-aged guy like me, I wish you all well, and I think, you know, it's a lesson for all of us to you know, to be aware of who we are and take care of ourselves and our loved ones as well. So thank you all for joining us. Listen, before we leave, in the back, we do have plenty of material from Chairperson, from H3, and from the JCC if you want to find out more about all of our organizations. Thank you all so much also to Baptist Health and the Miami Cancer Institute.
And
Thank
I
you
want
all
to
so
say
much.
something as well.
And to the Miami Beach Chamber of Commerce. And if there's any last words from you.
I want to thank you. This panel it's amazing. You know, you came here, you kind of share your expertise, your experience, your knowledge with us. You took your time to share with us. So thank you very much. And I want to let you know that it was a pleasure to be the moderator of this significant event. And I want to thank you. Again, I want to thank JCC, you, Danny, thank you. Deborah from Chairperson, thank you very, very much. And stay tuned because we have so many things, great things coming for H3. It's exciting. So good evening and thank you.
Good night, everybody.